Okay, so this is for neurophysiology, and we're just gonna talk this out because I think that's gonna help me remember. Also, I have my little helper here. Love you, Quinn. You're so smart. Okay, where to start? So, I think knowing your receptors is super important because you can then figure out what drug is going to do to that. So alpha 1, it's going to vasoconstrict all of your vasculature, increase your blood pressure. And then alpha 2, I remember this because Precedex works on alpha 2. Don't really like Precedex. My heart rate always goes in the toilet, and so I have to turn it off. And so this makes sense because Precedex is an alpha-2 agonist. It's going to decrease my norepinephrine release from the presynaptic cleft. It's going to decrease my insulin release, and then it's also going to decrease the aqueous humor secretions in your eyeballs. So basically just decreasing all of those CNS responses. Let's see, and then B1, it's going to increase your heart rate. This is mostly heart stuff here. Increase your heart rate, increase the heart's contractility, and increase the rate of conduction. It's also going to increase your renin secretion in the kidneys, and that's going to help your blood pressure as well. B2, we love these in anesthesia. They bronchodilate. They also vasodilate your skeletal muscles. So if you're like running away from a bear and you need your skeletal muscles to run, it's going to vasodilate and send blood to those muscles so you're able to run as fast as you can, which I would die. Glucolysis, it's going to dump a bunch of glucose into your system, makes it available for your brain. Also to note, your brain doesn't need insulin to take up glucose, and so these two actions help the brain get as much glucose as it can to think within that fight or flight response. The ciliary muscle relaxes in the eye, so it dilates your pupils so you can see far. And then this should say B3. B3 is lipolysis. Really not that important. Maybe if you want to lose some weight. And then modulation of neurotransmission happens with M1. These are mostly parasympathetic at this point. So basically just, what neurotransmitters are released at this point. M2 decreases your heart rate, decreases the contractility, decreases rate of conduction. So, if you're in AFib, RVR, you might want some M2 going on. And then M3, your smooth muscles are going to contract. That's going to increase that blood pressure a little bit. Increased gland secretion, so increased salivary glands secretions. And then this one's interesting. It kind of contradicts the muscle contraction here. It's vascular and endothelium vasodilate. So I think that pretty much counteracts the blood pressure effects on this one. So mostly just gland secretions there. And so if we know all of those and what those do, we can then figure out, okay, how, if I stimulate these, what's going to happen? And so knowing these proteins and what they do helps us understand if it stimulates the receptor or if it inhibits the receptor. So GQ coupled proteins, those are secondary messengers. And with those type of protein gated ion channels, it will increase your IP3, which also increases your DAG. It does that by increasing the phospholipase C action. And all of that to say that this will increase your intracellular calcium levels, which will give you a neurotransmitter release. So GS, I remember this as stimulatory. This is a different type of coupled protein. it stimulates calcium release, but it does it in a different mechanism. It increases your cyclic AMP, and it does that by increasing your adenyl cyclase activity. Again, increasing intracellular calcium levels, releasing a neurotransmitter that can act on its site. GI, I think of GI as inhibitory. It decreases the CAMP by inhibiting the adenyl cyclase, and also it increases the potassium that leaves your cell. So cells are usually negative in general. Potassium is a positive ion, so if you have positive ions leaving the cell very quickly, your cell's going to become even more negative, and so it's going to hyperpolarize. And so that's going to make it harder for an action potential to happen. No neurotransmitter will be released. And so if we come back, bring it all together here. I've put my little baby to sleep. Anyway, come back to here. Now we know, okay, so my A1 receptor that vasoconstricts is a GQ coupled protein. And I know that GQ is going to increase my IP3 and DAG, which increases intracellular calcium, and I'm going to get some neurotransmitter release, and it's going to cause vasoconstriction. So by knowing all of this business and knowing this, you can figure out what type of response you're going to get. So with GI, it makes sense. It's inhibitory. My Precedex, inhibitory, is going to inhibit the CNS. It's going to make you sleepy. You're going to have decreased norepinephrine release. All of that's making sense, right? So now that we know those and we can kind of figure it out from there, where shall we go? Let's start with maybe how different ion concentrations can affect neurotransmitter release. So a neurotransmitter release, it doesn't happen unless calcium enters the cell. It's calcium dependent. So if you have hypocalcemia, that causes, so calcium is what regulates your sodium ion channels, and if you're low on calcium, your sodium channels are going to be leaky. If you have this positive ion floating around, it's going to depolarize your cell faster and create an action potential. This is how we get like tetanus and sustained muscle contraction, so we don't want that. So that's why we always try to give intracellular calcium, and we give it slow. And then hypercalcemia, this actually decreases the cell's permeability to sodium, and so it hyperpolarizes the cell. So you're not going to get an action potential. And if we think about it, if we give IV calcium, we usually give that when people have really high potassium. And so we do that to decrease the potential for polarization, because we definitely don't want them having arrhythmias. And so if we hyperpolarize that cell by giving calcium, we're less likely to have arrhythmias. Now, hypocalcemia, this makes sense because if you have lower potassium, potassium is a positive ion. If you don't have as much positive ion going around in that cell, it's going to be more negative, and so it's going to be even harder to depolarize, aka hyperpolarized. So it's going to take even more calcium to depolarize that cell. Hyperpotassium, you're going to have more positive ion in that cell, so it's easier for an action potential to occur. And then this one I find interesting. This makes sense because magnesium is a calcium antagonist. So if we want our muscles to stop contracting, if we have some twitchy muscles, we take magnesium, right? That's because it blocks calcium release. Calcium release is what causes a neurotransmitter release that causes a muscle contraction. So that makes sense, right? Okay. Now, let's think about how different processes, like in the ICU, we see acidosis a bit. So how these processes basically affect the excitability or unexcitability of the cell to depolarize. So alkalosis, it actually makes it easier for a cell to depolarize, and they're excitatory, so you'll have more neuronal action here. Acidosis, this makes sense to me because I think about my COPD patients on the BiPAP. They're super sleepy, right? It decreases CNS activity, decreases its sensitivity to things. Oh gosh, I've been talking too much. Post-tetanic is an increased response. And we get this because after we've stimulated that nerve so many times, you get a dump of acetylcholine. So all that calcium is rushing in, you're dumping acetylcholine. More acetylcholine is gonna mean you have better chance of it connecting to a muscle fiber and it contracting. So you're gonna have an increased response with each increase. Hypoxemia, this one is for real here. Like if you are hypoxemic in your cells, not just, you haven't been breathing for a few seconds, but your cells are without oxygen, you're gonna have absolutely no response, period, done. So that's not good. And then fatigue, this one makes sense. Think about working out, your muscles are fatigued, they don't have enough ATP to move in that calcium, so you have a decreased response. And then this is just a reminder that the ATP ACE pump is a energy-based pump. It moves 3 sodium ions out and 2 potassiums in. That keeps the cell regulatorily more negative. Okay, so we've talked about a lot there. Let's kind of switch gears a little bit. There are different nerve fibers, and this is important in anesthesia because different nerve fibers take up anesthesia differently. So for example, local anesthesia, your B fibers, the preganglionic autonomic, are going to be the very first to take up that local. So let's get into it. Alpha, they are motor skeletal, and they mostly are just for proprioception. Alpha B, these are sensory. They're mostly sensitive to pressure and a little bit of touch. Let's see, gamma, we have motor. This is basically what helps with muscle tone, keep that muscle tone intact. And then delta, these are our fast pain fibers. So we definitely want to get these bad boys blocked for our patients. And so it's going to take a little bit more local anesthetic because these B fibers are in the way first, and then we have our fast pain fibers. So these are going to soak up all that local anesthetic before it even reaches the fast pain fibers. So we got to remember that when we're dosing those bad boys up. Lastly, we have the slow pain fibers. These are also on your postsynaptic sympathetic ganglion. Important, yes. As important as slow pain, probably not. So let's look at saltatory conduction. So when you have your nerve fiber, myelinated fibers have little junctions where in between the myelinization, and your impulse can actually jump from those junctions. Instead of traveling the whole length of the nerve fiber, it can jump. And so that makes it a lot faster, up to 10 times faster is what the book says. So this also decreases the energy needed to send those signals. And that's because as it's jumping, it's not having to depolarize along the whole nerve. It's only depolarizing at these junctions. And so the amount of sodium and potassium, ATP, needed to pump in and out to depolarize and repolarize the cell isn't as much as if we were doing the whole nerve section. So that makes sense there. And then let's see here, talk about this bad boy. So the spinothalamic tract, this tract senses pain, temperature, crude touch, and crude pressure. It's crude and not very localized because it's deep within the spinal cord, more anterior. This actually will ascend, so it's spinothalamic, so it comes from the spine, ascends to the thalamus. It decusses, which this is a weird word, but it crosses at the spinal level where it synapses. So you're going up, 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 it's going to cross and then head up to the thalamus. So wherever, these are kind of tricky because they can either synapse right at the spinal level that the action potential happens, or it can go up or down a few levels and then synapse. No rhyme or reason that I've noticed. I'm sure my teacher could say otherwise, but for our purposes, it will cross wherever it synapses and then head up to the thalamus. Let's see. And the pain synapse is in the substantia gelatinosa. Freaking weird. It's a weird place in gray matter within the spinal cord, and the pain signals synapse there. And this makes sense because this area, the gelatinosa, has a lot of substance P. Substance P are what help, that's the neurotransmitter for pain signals. All right, enough about that. Let's see here, the medial lemniscal tract. This one also ascends, it's sensory, it goes, let's see, so it's fine touch, not crude. This one is fine touch, pressure, temperature, vibration, and proprioception. It's 2 discriminatory touch, and this one's not as deep, so that's why. And it travels up the ipsilateral side. Wherever this action potential occurs on the spinal cord, it's going to go up that same side, and it doesn't cross until it reaches the medulla. Once it reaches to the medulla, it's going to go through the medial lemniscal tract all the way up to the cerebellum. Or not the cerebellum, sorry, the cerebral cortex. Cerebral cortex is the bad boy that does everything for us, basically, in a nutshell. And lastly, so up here I've written out the neurotransmitters for these different, like for our G proteins. So for our G proteins, they use different neurotransmitters to make whatever action they want to make happen. So for the G-coupled proteins, we have acetylcholine, norepinephrine, endorphins, serotonin, dopamine, histamine, and substance P. So substance P, that's where we talked about that regulates the pain fibers. Histamine, that's in your RAS system. So that's why antihistamines, that'll block histamine and make you sleepy. Histamine also dilate your blood vessels. And so if you have a big histamine release, like with opioids, you will have hypotension. Dopamine, that plays a critical role in the reward system in the brain. Dopamine can be inhibitory or excitatory depending on where it binds. So you kind of have to get pretty detailed to know what action it's going to happen. But it plays a key role in anesthesia because it's a key role in addiction. So, you know, it depends on our patient and their dopamine receptors. Are they going to need more anesthetic or less? Serotonin, this bad boy, I don't really understand serotonin that well. All I know is it is in the chemoreceptor trigger zone. So we have like Zofran and those things that block serotonin. Endorphins, these are released after exercise or with anxiety and stress or fear. Endorphins are actually natural endogenous opioid agonist. And so it's going to give you that same feeling that an opioid drug would. Obviously not as potent, but that's why they feel so good after we exercise. Norepinephrine, this is another neurotransmitter that helps with usually it's with sympathetic response, so the fight or flight. And then acetylcholine, we use that in everything. It's mostly used for cholinergic or parasympathetic neurotransmitter, but it's released presynaptically for every type of presynaptic autonomic responses. So that's the neurotransmitter we need to have any type of response there. And so lastly, we have the ligand-gated receptors, and they have different neurotransmitters for them, of course, because we gotta be more complicated, right? So inhibitory neurotransmitters, meaning we're not gonna have a response, calcium's not gonna be released, we want to depress whatever action we want. GABA, it's the major inhibitory neurotransmitter of the CNS. GABA, like for propofol, we love that. GABA works by releasing lots of chloride ions and hyperpolarizing the cell. Glycine can either open the chloride ion channel and hyperpolarize, or it can increase the efflux, or basically make potassium leave the cell. So as potassium's leaving the cell, it's positively charged, so it makes the cell more negative and hyperpolarizes it. So no action's going to occur there. Excitatory neurotransmitters for these ligands, so we want the action to happen, we want something to occur. Serotonin, acetylcholine, and glutamate. Glutamate is the major excitatory muscle for the CNS. So that makes sense there. Acetylcholine, that's going to make things happen. And also the serotonin, like I said, I don't really understand that very well. But these neurotransmitters are released. And what happens is calcium and sodium ions are released. That's going to depolarize that cell and make an action potential occur. And so like this all comes together because you're like, okay, so what action potential, what's going to occur, what doesn't occur? It all depends on what receptor it's acting on. So if we're wanting, to stimulate A2, we want an inhibitory response, because an A2 is a GI inhibitory gated receptor. So we're gonna go, we'll just look over here. So we know that norepinephrine release, the neurotransmitter, is decreased. So we're not gonna have calcium. And this is gonna help us with our Precedex. It helps us to get our patients hopefully a little sedated, but really honestly, I've just seen it decrease your heart rate and blood pressure. So anyway, that is what I have. Oh, I didn't talk about this little part here. The CBF is cerebral blood flow, and autoregulation of cerebral blood flow is awesome. We love it because we don't have to mess with it. As long as your MAP is between 60 and I believe 120. So as long as you got a pretty normal blood pressure, you're auto-regulating and we don't have to worry about this. But anesthesia, we mess stuff up. So auto-regulation is disrupted by our volatile anesthetics. So we gotta monitor that. You want cerebral blood flow because if you don't have that, we could incapacitate our patients and they won't wake up. And that is super horrible. So we gotta make sure we have enough cerebral blood flow because we are disrupting autoregulation with our anesthetics. Ischemia, people with strokes, that will disrupt that as well. Hypoxemia, that kind of goes hand in hand. And then hypercapnia. So if you're got a high CO2, that can also disrupt your cerebral blood flow as well. All right, that's all I got. My sweet baby. All right, let's get it.